this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 5 conversations from episode 24, our review of last week's Innovations in NAFLD Care Congress, Year 2. Plus, from the vault, conversation 24.1 from Season 3, our review episode from last year's INCBCN 1. This closing conversation covers the highlights of the second day, including the EU Pearl program, the debate about the value of curing NAFLD and NASH with a vegetarian diet or not, a wrap-up from Stephen Harris on upcoming medical therapies, and 2 presentations from Italians that covered a couple of really fascinating topics. Jeff described the debate as great and hopes to expand on this idea next year. We moved through the rest of the day quickly and on to the 2 final questions I asked, listen to hear what they talked about, what we all talked about, frankly, and where it all went. INCBCN is a different concept of what a medical conference can be. Year 2 is not the same as Year 1, but, like Year 1, was an exciting meeting driven by a different perspective of what it wanted to achieve. It's an excellent conference and occasionally eye-opening, an opportunity for you to listen, sit back, enjoy, learn, and when you're done, join the discussion in our LinkedIn discussion group.
Jörn Schattenberg.
We had Dr. Elena Sena speak on, give an oral short abstract presentation. She's part of the EU Pearl initiative, which is an EU-funded consortium developing a patient-centric collaborative research platform, which I thought was great, and I hope we're going to hear more. Clearly, one of the highlights was the lifestyle intervention NAFLD treatment and care session, and we had a pro and con proposition for curing NAFLD by being vegetarian. Shira Salvasaji, who's well known for all her strong work around the impact of red meat, did very well presenting. She was proposed against the position by Camilla Dalby-Hansen, who's done a great job, and actually a clinical trial with liver biopsy confirming that high-fat, low-carb isn't actually, or is also an alternative to staying totally meat-free. I felt there was a lot of Twitter discussions around this, so we were successful in reaching out and getting people that weren't even attending, commenting on these sessions, so that was great. Stephen gave a wrap-up on the available medical therapies, and then we had additionally 2 presentations, both given by Italian fellows actually, discussing time-restricted feeding and social jet lag, which is kind of a new concept for me. So that was part of the abstracts we selected to be for oral presentations. I felt that was a very strong session. I'm not sure, Jeff, you have anything to add?
Jeffrey Lazarus.
It was. I think, Roger, having a debate was just great. They were both amazing. They were very convincing. They used a lot of evidence. And I think that's what we need is open debates. Next year we can do some voting pad, anonymous voting about it. But, it was really great to discuss these issues in a debate format. After that session, we moved into talking about inequities, what some call disparities in fatty liver disease care, both for women, but for those of lower socioeconomic status, minorities, and others. Patricia Carrieri and Juanma Periquez both made really nice presentations because we don't address this enough. We need to remember, even as we scale up diagnosis and get people aware of their fatty liver disease status and into clinics and hospitals, we're going to leave the poorest behind once again, and they're the most affected. So that goes back to what I said earlier about thinking about the entire development and health agenda and why we need preventive hepatology before you get to the hepatology unit, because many people are not going to get there. And we attested to that the next day when we took our clinic, as we do every weekend, into the community where people really don't go to the health system unless it's an acute situation, and we're finding 10% hepatitis B positivity in that population. We've tested over 1,000 people over the last couple of years. We then had a closing session about what it's going to take to drive the field forward. Camila was back on the stage, joined by Ken Kuzi and others, and we and really, in this I'd say the whole audience was on the stage because everyone was discussing, and that's been a hallmark of having a small meeting, is that everyone's been there the whole time and they're discussing. So we really talked about 6 or 7 key issues to drive the field forward. It was pretty obvious, and I tried to limit the discussion because we all agree that we need to resolve the nomenclature issue, adopt the new nomenclature that was agreed on by a majority, and I know it's been discussed here on Surfing the NASH Tsunami. But then we talked about what are the other things we can do, the importance of multidisciplinary teams, how to engage manage people early on in a whole range of issues.
Roger Green.
So, Jeff, slightly counterintuitive point. Listening to that discussion, I wondered whether that made it easier for the name change or harder for the name change. And here's where I'm going. If you go back to where we were 20 minutes ago in this conversation around preventative hepatology, the name change makes it easier for everybody in hepatology to get aligned, but might make it harder to explain to people outside hepatology what we're talking about, simply because it's a more cumbersome structure with more big words. I know when I look at that as someone who's looking for precision, I love it. And when I look at that as somebody who's looking for communication and simple explanation, I wonder how easy that's going to be to do. And I had a similar reaction listening to that discussion.
Jeff is very intimately into the whole process and also the technical aspects. If I see it right, you need, and I'll let you have the last word on this, Jeff, but you need an overarching theme that unifies certain things, and then you might need some granularity to actually subdivide aspects that we're not 100% sure yet we've got right, but that offers the specialities a way forward to differentiate certain disease phenotypes.
I would just add that some people will go on using the terminology that we have now. They'll call it fatty liver disease, and for them it will be important to say that it's not alcohol related, so that it's non-alcoholic fatty liver disease. That's fine. As we report it for reimbursement when it's listed in ICD, it will be with the new terminology. But those who earlier proposed that it's metabolic associated have done us a great service, and that's the new name. I mean, that was already shared at ASLD in the autumn and again at DDW. So it's metabolic associated steatotic liver disease. For those who are talking about alcohol or fat, even if it's fatty liver disease is problematic, they have an alternative now, which they can just come home and say, I have SLD, it's a liver disease, and this is what I need to do. So I think it serves both sides. It's not a Taliban approach that you have to use that name every time you talk. In fact, we'll find ourselves explaining SLD by talking about excess fat in the liver. So we're not going to avoid it entirely, but it gives you the opportunity to basically go back and say, this is what I have, if using that terminology doesn't work in your community.
What's so interesting about this whole discussion is that when we start rolling it out to the world, we're going to learn a lot that y'all got right, and we're going to learn a couple of things that didn't work the way people would have predicted, and then we'll have to figure out what to do about that as we go along. That's not in any way to belittle the process, which I thought had a tremendous amount of work done by a lot of people, well-intentioned, and I'm not sure you could have come to a better answer, frankly, given the path that everybody chose to go down.
Well, like I said, that was a very small part of the discussions. We really wanted to talk about how to drive the field forward, what needs to be done. And there was great agreement, as expected, on the important role of non-invasive tests, making them more easily accessible, making more people aware of their fatty liver disease, of engaging more with endocrinologists, engaging more with GPs, engaging more with patients and the community. So that kind of came to the fore in this meeting that's, different than many others, that state-of-the-art talks, but then really state-of-the-art discussions where, we had people who knew very little about fatty liver disease in the field, in the audience asking questions, and we had the leading experts in the world also asking questions. So it was fascinating.
Two closing questions. Number one, anything you heard from the audience in the meeting that really surprised you?
For me, it wasn't a surprise because I've spoken with Chris Kopka before, who I've known a long time, but he gave a very nice car analogy and said, really, a lot of the safety on the road is because cars have been made to be more safe.
Yeah, that was great.
And it reminded me, or reminded all of us, that some people will change their behaviors, but as any hepatologist will tell you, and nutritionists, it's hard to get that behavior change. That's also why we want drugs to be available for those who have that challenge. And so what really his analogy was we need to make food safer. We need to change what people are eating so you can, I added on to that, the example of a colleague I worked with, Scott Ratson, who went to Anheuser-Busch and worked with reducing the amount of alcohol in beer so people could still keep drinking when they watched their sports, but there was a little less alcohol in it. And so what Chris was getting at was, can we get rid of the ultra-processed foods? And for those who are not really going to change their eating habits, can we make some of that food healthier? And so I like that, how we start to change the structures and systems. It's challenging, but it would make a big change very quickly. And I think that took some people by surprise.
Jörn, anything you found surprising coming from the audience or in the meeting itself?
It took me by surprise, and it's that insight, from people that have been working in public health or in general aspects. I'm always so focused on the liver side of things, and it's really a nice thing about INCBCN is that it helps me look up from my little dish and see the entire table.
Yeah, that's an interesting way to put it. I have to agree. I thought the metaphor about cars was probably the most out-of-the-box thing I heard in the entire meeting. And I had the same reaction. I said, boy, that's smart. A lot of medicine is about what we ask the patient to do as compared to what situations we put the patient in where she or they are more likely to succeed. Second question, what will be different next year? To the degree you can figure that out yet?
Well, we may have the same venue. It will be in Barcelona again. Hopefully we'll have a surprise. So I can't tell you what that is. That'll be different. But I think, we'll expand the endocrinology session, as I mentioned, and go more international with it. We're discussing a possible call to action to launch. So more on that when we get further along. And we want to engage more with primary care. And we want to figure out how to make the NIT session, both the lectures, but also the hands-on session, even more engaging so we can really try out more types of tests.
Fantastic. Jörn, from your perspective, anything not in the either if not in the program, then simply in the way the meeting feels or the feel, form, function of it?
For sure, we aim to keep the diversity up and involve younger folks and get, the hands-on experience of doing liver exams and taking it out to different areas. I think that's something we want to maintain and build on.
We also are discussing, it's only about 72 hours since the meeting. We did have one meeting, but about next year, but we'll pick up on that in a couple of weeks. But also maybe having a young investigator session for an hour and talk about, their priorities. As the drugs advance and are in early phases, we need to think about the next generation. And we've been talking to some young people, some who spoke in this edition of INCBCN, but maybe having them drive a session and hear from them what their priorities are. So we're going to get more engagement, expand the steering committee, expand the scientific committee, and start to listen to more people so that, it's a responsive meeting to what people feel the field needs.
That's very cool. That's a great note. Louise, any questions, comments? Other than next year, maybe you and I will both find a way to be there, which would be a good thing.
Louise Campbell.
Yeah, I'm just excited to see where it goes. We're closer to drugs now. Although we've been turned down for obeticholic acid, we are closer to drugs to be able to offer our patients, but we're not closer to the education that's needed in the medical, nursing and allied health fields. So we have a big problem that if we don't start to address the education at those levels, it doesn't matter how many drugs we have, we cannot educate patients. To some extent, the nomenclature may or may not assist that, because I think the one thing that allied health are particularly good at, and nurses, is being able to put it in the language of the person in front of you and using analogies and making the diagnosis and the discussion very visual and informative in a way that somebody can understand. But we do need the concept of where it's coming from, where it's going to, and how we can assist in that. But it cannot just be dumped on allied health at the end. So these pathways have to be taking in the lack of resources that we've currently got, and how do we maximize the resources that we've got with the ability to put it in, because we are talking about arguably one of the biggest health challenges with new medication to get it out there into those populations, but also the education that we've alluded to earlier about being able to educate upstream when we find poor liver health that drives other diseases, or other diseases that drive poor liver health. So that is a massive conversation to have, and it is certainly an area that is considerably lacking in any planning that I've seen. So I'd like to see some planning of how that can be looked at, because we've got some great discussions coming out of the last two meetings. Let's put some practicalities into making those in a pathway of that sort of nature.
I couldn't agree with you more, Louise. And one of the organizing committee members was stressing how we should really focus on pathways, a whole range of pathways, exactly what you're saying, in line with our discussions on expanding the community of practice and expanding the models of care. We need to look at each pathway. What's it going to take to have an efficient pathway in endocrinology, in GP services? And we talk about GP services as if it's one thing, but they're so contextualized by country within countries and different cities that we're going to need to think of really dozens and dozens of pathways with little tweaks. Sometimes you'll need a peer to help you get there. Sometimes you'll have to go to the community. Sometimes someone will just walk in and have their test automatically ordered, FIB4, like with Javier Crespo in Cantabria, or through, the iLift with John Dillon and company. But we're going to have to think about all of these different pathways. So I think that's going to be a big focus next year as well.
Well, that'll be exciting. That'll really be exciting. And by next year, ideally, we should have at least one drug, which would put a whole different spin on all this.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. Next week, we will post after the end of International NASH Day, after you have had the opportunity to consume a day of fantastic liver presentations. Until then, stay safe, surf on. We'll see you next week on the podcast. Bye-bye now.